Welcome to the funnel effect. Prasugrel versus clopidogrel for patients with unstable angina or non-ST segment elevation myocardial infarction with or without angiography. A secondary pre-specified analysis of the TRILOGY ACS trial, published in The Lancet in 2013. And we have a massive list of authors who contributed to this global effort, so bear with me here. Stephen U. Iviot, Harvey D. White, E. Magnusoman, Keith Alley Fox, Paul W. Armstrong, Dora Raj Prabhakaran, Gail Hafley, Yulia Lokmagina, William E. Bowden, Christian Ham, Peter Clemenson, Jose C. Nicolau, Alberto Manuzzi, Witold Ruzillo, Peter Ladinsky, Ali Otto, Jose Leva Pons, Gregory Pavlides, Kenneth J. Winters, Matthew T. Rowe, and Deepak Elpat.
Yeah, that is quite the list of investigators for this one.
It really is. So to kick off this deep dive, I want you to imagine taking your car to a mechanic, and it's making this terrifying rhythmic clunking noise coming from deep inside the engine block.
Right, a sound nobody wants to hear.
Exactly. And the mechanic listens for like 5 seconds and gives you two choices. Option one is they guess what's wrong based solely on the acoustics. They assume you have a carbon buildup and they just pour a highly caustic, heavy-duty chemical treatment directly into your gas tank.
Okay, that's risky.
Yeah. And then option two, they physically take apart the engine block, they get a borescope, look directly at the cylinders to confirm the exact mechanical failure, and then decide if that aggressive chemical is actually going to fix the problem. Or, if it might just melt your seals for absolutely no reason.
Well, obviously, you'd want them to look.
Right. When it comes to a vehicle, almost all of us demand visual confirmation. You pop the hood, you look at the problem.
Yeah.
But what happens when the engine is the human heart and the mechanic is an emergency room physician? Today's deep dive is about a massive paradigm shift in cardiology that forces us to question how we treat our most vulnerable patients.
It really does. And the central tension here is just incredible. We are looking at how the simple act of visual confirmation, which is a procedure known as angiography, completely redefines the efficacy of a remarkably powerful blood-thinning medication.
Which is wild to think about. A test changes how a drug works.
Exactly. I mean, this paper takes a drug that was highly anticipated to be a universal lifesaver and shows that its power is entirely conditional. It either acts as a profound shield against a catastrophic cardiovascular event or, well, it acts as a completely useless chemical circulating in the bloodstream, achieving absolutely nothing.
Wow.
Yeah. And the deciding factor isn't the patient's genetics or their age, but whether their physician decided to literally look inside their coronary arteries before writing the prescription.
That conditional efficacy is what makes this a true medical detective story. But to fully appreciate the mystery that the TRILOGY ACS trial uncovered, we need to establish the baseline. Like, what are we actually dealing with here?
Right, the clinical context is crucial. We're talking about acute coronary syndrome, specifically unstable angina and non-ST segment elevation myocardial infarction, which we call NSTEMI.
So we aren't talking about stable patients who just get a little winded on a staircase, right?
No, not at all. These are patients arriving in the emergency department in acute distress. The pathophysiology here is a ruptured atherosclerotic plaque.
Okay, so the endothelial lining of the coronary artery tears, exposing the lipid core, and then the coagulation cascade just goes into hyperdrive.
That's the exact biological trigger. The body perceives that ruptured plaque not as a disease, but as an injury that needs to be patched immediately. So it initiates a rapid, aggressive platelet aggregation response.
It's trying to stop bleeding that isn't really happening.
Precisely. In unstable angina, that platelet-rich thrombus is forming and breaking apart. That's what causes that transient severe ischemia, that crushing chest pain at rest. The artery is critically narrowed, but it's not completely permanently occluded.
Got it. And then how does that differ from an NSTEMI?
Well, when it progresses to an NSTEMI, the subendocardial tissue, the innermost layer of the heart muscle, is actually starved of oxygen long enough that it begins to necrose, or die.
Which sounds awful.
It is. And that cell death leaks biomarkers, like cardiac troponin, into the bloodstream. That's how we definitively diagnose it, even if the electrical tracing on the EKG doesn't show the massive, full-thickness infarction that we'd see in a classic STEMI.
Okay, so the immediate medical imperative is to halt that platelet aggregation. We have to make the blood less sticky, and we have to do it fast.
Exactly. And the standard of care for that is dual antiplatelet therapy, or DAC-BT. You hit them with aspirin to block the thromboxane A2 pathway, and you pair it with a P2Y12 receptor inhibitor.
Right, and for years, the gold standard second drug was clopidogrel, But clopidogrel has some serious pharmacological limitations, right? Which is why the newer drug evaluated in this trial, Prasugrel, was developed.
Yeah, we can't just say Prasugrel is stronger. We really need to understand the mechanism. Clopidogrel is a prodrug, meaning it's biologically inactive when you swallow it.
So the body has to process it first.
Yes, it requires a complex two-step metabolic oxidation process in the liver, and that process is heavily dependent on the CYP2C19 enzyme.
And let me guess, that hepatic dependency is clopidogrel's Achilles heel.
You nailed it. A significant percentage of the global population has genetic polymorphisms in their CYP2C19 alleles. They are poor metabolizers.
Meaning the drug just doesn't work as well for them.
Right. You can give them a massive loading dose of clopidogrel, but their liver simply cannot convert it into the active metabolite fast enough, or in high enough quantities to adequately block the P2Y12 receptors on the platelets.
So you think you're protecting the patient, but they're basically walking around with high on-treatment platelet reactivity.
Exactly. Prasugrel was engineered to bypass this exact bottleneck. It is also a prodrug, but it's rapidly hydrolyzed by esterases in the intestine and then only requires a single rapid cytochrome P450 step.
Oh, so it skips the whole genetic enzyme issue entirely.
Pretty much. It delivers a faster, more consistent, and much more profound platelet inhibition across the board, regardless of your genetics.
Knowing that prasugrel is pharmacologically superior at inhibiting platelets, I mean, it makes sense that earlier landmark trials showed it dominating clopidogrel, like the TRILOGY 38 trial or the Plato trial with a similar drug, ticagrelor.
Yeah, those trials showed these newer agents absolutely crushing clopidogrel in reducing cardiovascular death and recurrent myocardial infarctions. The data was incredibly strong.
But there was a massive caveat to those earlier successes, wasn't there?
There was a huge one. Almost every patient who saw that massive benefit had a physical intervention. They underwent percutaneous coronary intervention, or PCI.
Meaning the doctors went in, inflated a balloon, and placed a metal stent to prop the artery open.
Exactly. The clinical community looked at TRILOGY 38 and concluded that intense P2Y12 inhibition is phenomenal at preventing stent thrombosis.
Because stents are foreign objects, right? The body naturally wants to clot around them.
Right. And Prasugrel prevents that beautifully. But it left a gaping hole in our medical knowledge. What are the patients who don't get stents?
Yeah, what about them? What if their coronary disease is too diffuse for a stent or their vessels are too small?
Or what if they are managed in hospitals where interventional cardiology just isn't readily available? These patients are medically managed. They rely entirely on pharmacology to survive.
Which is exactly why the TRILOGY ACS trial was designed in the first place. It was a massive global undertaking, specifically targeting medically managed patients.
Right, no stents, no bypass surgery, just the jugs.
They wanted to prove that the superior platelet inhibition of prasugrel would translate to better outcomes even without the physical hardware. And honestly, the biological logic seems bulletproof.
It does. If A is a stronger inhibitor of blood clots than B, and blood clots cause heart attacks, then A should prevent more heart attacks than B, regardless of whether there's a piece of metal in the artery.
But when the main Trilogy trial results were published, it sent shockwaves through the cardiology community because the result was completely neutral.
It was a profound disappointment for many. The primary endpoint curve for prasugrel and clopidogrel in the main Trilogy cohort basically tracked right on top of each other.
So statistically, the superdrug was no better than the standard drug for patients treated solely with medication.
Exactly. It violated the established pharmacological logic. When a clinical trial yields a result that fundamentally contradicts the biological mechanism of the drug, you have to look beyond the drug itself.
Right. You have to look at the trial design, and more importantly, you have to look closely at the patients who are actually enrolled.
Yes, and that leads us directly into the brilliance of the specific Lancet paper we are analyzing today. The investigators didn't just throw their hands up and accept the neutral result.
They conducted a pre-specified secondary analysis to find the hidden variable. So they looked at the 7,243 patients in the trial who were under the age of 75.
And they split the data based on one crucial, seemingly logistical decision made by the attending physicians before the trial even commenced.
Which was, did the patient undergo an angiography? Did the doctor thread a catheter up to the heart, inject the radiopaque iodine contrast dye, and use fluoroscopy to visually confirm the state of the coronary anatomy?
Right, and the split in the data is immediately revealing of global medical practices. Out of those roughly 7,200 patients, 3,085, which is 43%, had an angiography prior to being selected for medical management and randomized into the trial.
Okay, so 43% got the camera. That means 57%, the majority of the patients, were treated blindly.
Yes, they were diagnosed clinically based purely on their chest pain, their EKG changes, and their cardiac enzymes.
When you look at why that 57% didn't get the gold standard diagnostic test, it opens up a massive conversation about healthcare infrastructure.
It really does. I mean,
Yeah.
sure, 32% of those patients simply refuse the procedure. It's invasive, it carries risks, and patient autonomy dictates they can say no.
Totally fair. And another 12% had unsuitable anatomy or medical contraindications. But the glaring statistic is that 29% of the patients who didn't get an angiogram missed out simply because they were admitted to a facility that lacked the equipment.
Right. Nearly a third of the unangiographed population was dictated by infrastructure, not clinical judgment.
That is a vital reality check for how we interpret global clinical trials. A phase 3 trial like TRILOGY ACS is an amalgamation of deeply disparate healthcare systems.
Exactly. We tend to treat trial data as an absolute clinical truth, but it is heavily modulated by local socioeconomics.
The geographic disparities highlighted in this paper are just staggering. Like in North America, a massive 84% of the patients enrolled had an angiography. Western Europe was right behind at 80%.
But the moment you look outside those highly resourced, highly litigious medical cultures, the numbers just plummet.
Yeah, the Mediterranean basin drops to 56%. Latin America is 47%. East Asia is 32%. India is 24%. And Central and Eastern Europe were the absolute lowest at just 21%.
4 out of 5 patients in Eastern Europe were treated solely on clinical presentation.
Why is the standard of care so wildly divergent? I mean, is it just the raw cost of building a catheterization lab?
Well, cost is a massive factor, certainly. Establishing and staffing a 24/7 interventional cardiology suite is incredibly expensive. But it also comes down to systemic healthcare philosophy.
What do you mean by that?
Well, in the U.S., the fee-for-service model and a deeply ingrained culture of defensive medicine heavily incentivize maximum diagnostic testing. If a patient comes in with chest pain, the threshold to take them to the cath lab is very, very low.
Okay, so they look almost every time.
Exactly. But in systems with socialized medicine or constrained resources, like many Eastern European nations during the time of this enrollment, a cath lab is a tightly guarded regional resource.
You don't just use it to peek around.
Right. You do not utilize critical care transport and occupy a cath lab table just to take a look. You rely heavily on your clinical acumen, and you reserve the invasive procedures for patients where you are absolutely certain mechanical intervention is required to save their life.
Wait, if almost 30% of people didn't get an angiography simply because their hospital didn't have the machines, doesn't that skew the data?
It's a very valid concern.
Are we comparing rich hospitals to poor hospitals instead of just comparing two drugs?
Yeah.
How do the researchers ensure they aren't just measuring wealth disparity instead of the efficacy of Prasugrel?
It's a classic confounding variable, and the authors of the Lancet paper were highly aware of it. You cannot do a raw, unadjusted comparison here.
So what did they do?
To isolate the drug effect, the statisticians utilized multivariable Cox proportional hazards regression models.
Okay, that sounds intense.
It is a complex statistical technique that essentially forces the math to artificially equalize the two groups based on baseline characteristics. They adjusted for regional differences, age, baseline renal function, prior myocardial infarctions, and a host of other covariates.
Ah, so they are trying to create a statistically level playing field to see if the divergence in the drug's performance holds true, irrespective of the patient's zip code.
Exactly. They have to control for the environment to see the true biological effect.
And as we dig into those baseline characteristics, we find that the difference between the two groups goes far beyond geography. When you analyze Table 1 of the paper, which outlines who these people actually are, a glaring paradox emerges.
It's a very striking finding.
The patients in the no angiography group weren't just geographically distinct. There were fundamentally different phenotypes. They were older. They had a significantly higher proportion of women, 37.8% versus 33.3%.
They also had much higher rates of prior heart failure. And crucially, they presented more frequently with unstable angina rather than an actual NSTEMI.
So, to synthesize all of those individual data points, the cardiology community relies on a highly validated metric called the GRACE risk score, right? the Global Registry of Acute Coronary Events score.
Yes, the GRACE score. It calculates a patient's probability of dying or having a recurrent myocardial infarction within 6 months.
What goes into that score?
It aggregates age, heart rate, systolic blood pressure, serum creatinine levels to assess kidney function, Killip class for heart failure, and whether cardiac biomarkers are elevated. A higher GRACE score unequivocally identifies a patient at a higher statistical risk of a catastrophic outcome.
And here is the mind-bending reality revealed in Table 1. The no angiography group, the patients who were treated blindly without the gold standard diagnostic visual, had significantly higher median GRACE risk scores.
That's right. The patients who were statistically the sickest, the most vulnerable, and most likely to die were the least likely to receive an angiogram.
I mean, in medicine, we assume that the sicker you are, the more aggressively we investigate. If someone is crashing, you escalate the diagnostics. But this paper highlights the exact opposite. This is the risk treatment paradox.
It seems entirely counterintuitive until you place yourself in the shoes of the attending physician standing at the bedside of a frail 74-year-old woman with a history of heart failure, fluctuating blood pressure, and a creatinine clearance that suggests her kidneys are already struggling.
Right.
The physician isn't withholding the angiogram out of negligence. They are withholding it because of the very real threat of iatrogenic harm.
Iatrogenic meaning harm caused by the medical intervention itself. Like, let's talk about the contrast dye used in the procedure. It's not just harmless food coloring.
Exactly. Radiopaque contrast media is notoriously nephrotoxic. For a healthy individual, it's a non-issue. But for a patient whose renal perfusion is already compromised by heart failure or age, that bolus of dye can easily tip them into contrast-induced acute kidney injury.
Or even permanent renal failure requiring dialysis, right?
Yes. Furthermore, the physical act of gaining vascular access, usually via the femoral artery in the groin or the radial artery in the wrist, and navigating a catheter through a highly diseased, calcified vascular system carries a baseline risk.
You could cause an arterial dissection, a massive bleed, or dislodge a plaque that travels to the brain and causes a stroke.
Precisely. For a highly unstable patient, the physical stress of the procedure might be the intervention that kills them. So the physician makes a calculated, protective decision to manage them non-invasively.
It's like taking a 15-year-old dog to the vet versus a 2-year-old dog. The older dog is much sicker, but you're way more hesitant to put them under anesthesia to find out exactly what's wrong because the test itself is risky.
That is a perfect analogy.
So we have two distinct populations established by this paradox. Group A got the angiogram. They are generally younger, have better kidney function, and lower GRACE scores.
And Group B was treated blindly. They are older, frailer, and at high risk for imminent mortality.
With the populations clearly defined, we finally get to unblind the data and look at how Prasugrel performed against clopidogrel in each specific cohort. This is where the statistics show an undeniable, fascinating divergence.
Let's start by looking at the overall primary efficacy endpoint, which was a composite of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke evaluated over a 30-month period.
Okay.
Validation of the GRACE score is immediately apparent here. Regardless of which drug they were randomized to, the no angiography group suffered significantly more events.
Oh, wow.
Yeah, 16.5% of them hit that grim composite endpoint, compared to only 12.8% in the angiography group. The risk scores accurately predicted that the frail, conservatively managed group would have worse outcomes.
But the real revelation, the data point that rewrites how we view these drugs, is found in Table 3. When the researchers isolated the group that did have an angiography, where the coronary anatomy was visually confirmed, Prasugrel demonstrated a clear, statistically significant superiority over clopidogrel.
Right. The event rate dropped from 14.9% with clopidogrel down to 10.7% with Prasugrel.
Which generates a hazard ratio of 0.77.
And a hazard ratio of 0.77 translates to a 23% relative risk reduction in major cardiovascular events. That is a massive, highly consequential clinical benefit.
So it proves that the biological logic was sound all along. Intensive P2Y12 inhibition does provide superior protection for medically managed patients.
Exactly. The drug works beautifully, even without a stent, provided you have correctly identified the target population.
But then we look at the group that did not get the angiogram, the frail, high-risk group that drove the neutral result of the main trial.
And this is where it gets interesting.
In this cohort, the event rate for Prasugrel was 16.3%. The event rate for clopidogrel was 16.7%. The hazard ratio is 1.01.
Basically dead heat.
Yeah. The p-value for the interaction between angiography status and treatment effect was highly significant. Statistically, in the unangiographed population, Prasugrel and clopidogrel were locked in a tie. The superior pharmacology of Prasugrel offered absolutely zero added benefit.
This is the crux of the entire analysis.
Yeah.
You have a drug that reduces risk by 23% in one room and does absolutely nothing in the room next door. And the only differentiating factor is whether the physician utilized a diagnostic camera.
So the stronger drain cleaner does work, even without the plumbing snake. But it only works if the plumber actually looked down the pipe with a flashlight first. Why does looking with a flashlight make the chemical work better?
Well, the act of looking with an angiogram doesn't magically alter the chemical structure of Prasugrel. It simply confirms that the patient actually possesses the biological problem that Prasugrel is designed to fix.
Let me use another analogy. Imagine putting premium, high-octane racing fuel into two different vehicles. Car A runs flawlessly and significantly faster. Car B sees absolutely no improvement in performance whatsoever.
Okay.
You start questioning the chemical makeup of the fuel. Did it break down? Is the octane rating a lie? But then you realize Car B has a completely dead transmission. It doesn't matter how potent the fuel is. If the underlying mechanical system isn't capable of utilizing it, the fuel is irrelevant.
That is a highly precise analogy, because the immediate scientific question the investigators had to answer was, did the drug fail pharmacologically in the unangiographed group?
Right. Did the frailty, the age, or the renal impairment somehow neutralize the active metabolite of Prasugrel?
They anticipated that exact question, which is why they incorporated platelet function substudies using the Verify Now system.
Verify Now is a point-of-care assay that measures P2Y12 reaction units, or PRU, right? It literally tests how sticky the patient's platelets are while on the medication.
Yes, and the Verify Now data was unambiguous. Prasugrel achieved highly potent superior platelet inhibition compared to clopidogrel in both cohorts. The pharmacology did not fail. The drug was actively binding to the receptors and shutting down platelet aggregation in the older, frailer patients exactly as intended.
Wait, if the pharmacodynamics are flawless but the clinical outcomes show zero benefit, there is only one rational conclusion.
The diagnosis itself is flawed. You are effectively treating a disease that isn't there. This paper shines a glaring light on the limitations of clinical syndromic diagnosis in acute coronary syndrome.
This is where the paper drops a statistic that should give every clinician pause. Relying on registry data, the authors point out that roughly 10% of patients diagnosed clinically with an NSTEMI and up to 25% of women with that same clinical diagnosis are found to have completely normal, unobstructed coronary arteries when they finally undergo an angiogram.
It's staggering. 1 in 4 women sitting in an emergency department experiencing acute chest pain, showing EKG changes, and having elevated cardiac enzymes do not actually have a ruptured atherosclerotic plaque.
Wait, so you're telling me that based on clinical symptoms alone, chest pain, EKG blips doctors are misdiagnosing a quarter of women and a tenth of men? Is clinical diagnosis without a camera just inherently flawed?
Well, the cardiology community refers to this broader phenomenon as minosa myocardial infarction with non-obstructive coronary arteries. When you rely solely on symptoms and biomarkers, you are casting a very wide net. You are capturing true plaque ruptures, but you are also capturing a massive amount of clinical noise.
What constitutes that noise? I mean, if it's not a blood clot choking off an artery, what is generating the crushing chest pain and leaking troponin into their bloodstream?
There is a myriad of severe acute conditions that perfectly mimic an NSTEMI on paper. Severe acute heart failure exacerbations can stretch the myocardium and cause troponin release.
Okay, that makes sense.
Hypertensive emergencies severely strain the heart muscle. We see myopericarditis, viral inflammation of the heart muscle, and the sac surrounding it.
Oh.
You also have Takotsubo cardiomyopathy, often called stress-induced cardiomyopathy, which heavily affects older women. And you have severe microvascular dysfunction, where the tiny capillaries deep in the heart muscle spasm, but the large epicardial arteries are completely clear.
So the main pipes are fine, but the tiny ones are freaking out.
Exactly. Furthermore, non-cardiac issues like severe gastrointestinal spasms or pulmonary embolisms can present with identical chest pain and ambiguous EKGs.
And here's the devastating realization. Not a single one of those alternative diagnoses, heart failure, myocarditis, Takotsubo, is driven by platelet aggregation.
Not a single one.
A P2Y12 inhibitor is entirely useless against a viral infection of the heart muscle or a hypertensive crisis. This perfectly explains the hazard ratio of 1.01.
It absolutely does. The no angiography group was heavily diluted with patients who never had a plaque rupture to begin with. When you give Prasugrel to a patient with a normal coronary artery, you cannot possibly prevent a heart attack because there is no heart attack to prevent.
The drug effect is mathematically washed out by the misdiagnosed population.
The clinical diagnosis, while necessary for rapid triage, lacks phenotypic precision. Angiography serves as the ultimate sorting mechanism. It purifies the trial population.
It separates the true atherothrombotic events from the inflammatory, hemodynamic, or microvascular events.
Exactly. When you apply Prasugrel to a pure population of confirmed plaque ruptures, its true potency is revealed.
Which brings us to a highly critical ethical and safety conversation. If we acknowledge that clinical diagnosis without angiography carries a 10% to 25% misdiagnosis rate, and we are aggressively treating these patients with industrial-strength platelet inhibitors, we are exposing a massive number of people to severe risks with absolutely zero potential for benefit.
Yes, Prasugrel isn't a benign supplement. Its primary mechanism of action inherently increases the risk of hemorrhage. The therapeutic window for potent antiplatelet agents is notoriously narrow. The goal is to inhibit aggregation enough to prevent a fatal coronary thrombosis, but maintain enough hemostatic function to prevent spontaneous catastrophic bleeding.
And the trial utilized two rigorous scales to track this danger, right? TMI, major bleeding, and GSTO, severe bleeding. We aren't talking about bruising or prolonged bleeding from a paper cut.
No, the TI major bleeding criteria define events like intracranial hemorrhage or a clinically overt bleed associated with a massive drop in hemoglobin requiring multiple blood transfusions.
Yeah.
These are life-threatening events.
Given how potent Verify Now proved Prasugrel to be, the obvious assumption is that the older, frailer, unangiographed group would experience a massive spike in fatal bleeds. But the safety data presented in this paper is surprisingly nuanced.
It is indeed. If we look closely at Table 5, the rates of severe life-threatening bleeding were remarkably low across the entire TRILOGY ACS population.
Wait, really?
Yes. While the numerical trend showed slightly more bleeding events in the Prasugrel arm, which aligns with its aggressive pharmacology, the statistical analysis, the p-values for interaction, showed no significant difference in severe bleeding between Prasugrel and clopidogrel in either the angiographed or the unangiographed cohorts.
This stands in stark contrast to the earlier TRILOGY 38 trial. In that trial, where every patient underwent PCI and received stents, Prasugrel was clearly associated with a statistically significant increase in major bleeding, including fatal bleeding, compared to clopidogrel. Why was the bleeding risk so successfully mitigated in TRILOGY?
The investigators learned from the Triton data. They adjusted the dosing protocols.
Ah, okay.
In TRILOGY ACS, patients who were over the age of 75 or who weighed less than 60 kilograms, the exact demographics highly represented in the unangiographed group, received a reduced maintenance dose of Prasugrel. They lowered it from 10 milligrams down to 5 milligrams.
That is brilliant. This pharmacological adjustment successfully threaded the needle, maintaining platelet inhibition without tipping the frail patients into severe hemorrhagic shock.
It really is a testament to adaptive trial design.
But representing the clinical reality on the ground, I have to ask, if severe bleeding was rare, why wouldn't a doctor just prescribe the stronger drug to everyone just in case? What's the harm if the bleeding numbers are so low?
Well, because doing so violates a core tenet of medical ethics and risk-benefit analysis. A low statistical risk of a severe bleed is not the same as zero risk.
Right.
When you prescribe a potent antiplatelet to a patient who, due to misdiagnosis, does not actually have a thrombus, you have fundamentally corrupted their risk-benefit ratio. Their potential benefit is zero.
So it's all risk.
Exactly. Any risk you expose them to, even a 1% chance of an intracranial hemorrhage, is entirely unjustified. You cannot validate exposing a patient to iatrogenic harm based on a diagnostic guess, no matter how educated that guess might be.
It's the equivalent of putting a cast on a leg that isn't broken, simply because the cast usually doesn't cause pressure ulcers. It's an unnecessary intervention carrying a necessary risk, which leads us to the broader implications of this paper. What does this deep dive mean for the future of clinical research and, more importantly, for patient care guidelines?
The authors arrive at a profound conclusion. When coronary anatomy is confirmed, intensive antiplatelet therapy is highly beneficial, completely independent of revascularization. This paper decoupled the drug from the stent.
Right. Prior to this analysis, the pervasive belief was that Prasugrel was essentially just a companion therapy for PCI.
Yes, but this data proves that the drug is a foundational therapy for the disease process itself, provided the disease is actually present.
For the world of clinical trial design, this paper is a glaring warning siren. The era of broad syndromic enrollment, running a billion-dollar trial simply on patients presenting with chest pain and elevated enzymes, is over.
It has to be.
If you design a trial without phenotypic precision, if you don't visually or biologically confirm the exact mechanism of the disease, your trial will likely fail. You will dilute your efficacy signal with misdiagnosed noise. Future trials must prioritize diagnostic purity over massive enrollment numbers.
It entirely shifts the paradigm of why we perform angiography. Historically, the angiogram was viewed almost exclusively as the immediate precursor to a mechanical intervention. You go in to look only if you are prepared to place a stent or prep them for bypass surgery.
But this changes that.
Yes, this analysis champions angiography as an essential diagnostic tool to guide precision pharmacology. The visual confirmation is the key that unlocks the correct medical management strategy.
And that is the most empowering takeaway for you, the listener. We delve into these complex hazard ratios and pharmacological mechanisms not just for academic curiosity, but because this dictates how you are treated in your most vulnerable moments.
Yes.
If you or a family member present to an emergency department with acute chest pain, and the clinical team recommends a purely medical management strategy, perhaps because of age or mild kidney dysfunction, you now possess the vocabulary to ask critical questions.
You understand the risk treatment paradox.
Exactly. You can respectfully ask the attending physician, are we sure what we are treating? Have we looked under the hood? Have we considered the misdiagnosis rates for NSTEMI, especially in women? Is there a way to safely confirm the anatomy before we commit to high-intensity blood thinners? You transition from a passive subject of medical protocols to an informed advocate for diagnostic precision.
Formulating those questions forces the clinical team to explicitly articulate their diagnostic certainty and their risk-benefit calculus. It elevates the standard of shared decision-making.
But I want to leave you with a final provocative thought looking toward the horizon. This 2013 Lancet paper exposes a frustrating paradoxical trap. We absolutely need the visual confirmation of angiography to accurately prescribe these powerful drugs. But the traditional angiogram requires arterial access, catheters, and nephrotoxic dye interventions that are actively dangerous for the exact frail elderly patients who need the accurate diagnosis the most.
It's a very difficult position to be in.
Right. If the diagnostic tool is too risky for the sickest patients, how do we break the paradox?
The resolution to the risk treatment paradox relies on the rapid evolution of non-invasive diagnostic technology. We are currently witnessing the explosion of coronary computed tomography angiography, or CCTA.
Oh, the ultra-fast CT scanners.
Yes. Using high-resolution CT scanners, we can now visualize the coronary anatomy, characterize the plaque composition, and rule out obstructive disease in a matter of heartbeats, requiring only a standard peripheral IV and a fraction of the contrast dye.
That's incredible.
Furthermore, the development of highly specific microRNA biomarkers and advanced AI-driven EKG analysis promises to differentiate a true atherothrombotic event from myocarditis or Takotsubo cardiomyopathy with a simple blood draw.
We are moving toward a future where we can achieve the absolute diagnostic purity of an angiogram without ever exposing a frail patient to the risks of the catheterization lab. We will be able to look under the hood with perfect clarity without ever opening it, and when we achieve that, we completely eliminate the guesswork. We pair the perfect diagnosis with the perfect, highly potent pharmacology, maximizing the benefit and minimizing the risk for every single patient, regardless of their age, their frailty, or their geography. Thank you for watching The Funnel Effect.